So before I start today's talk, let us discuss something more about bone and joint day. What is its significance in terms of use? What is peak bone mass? Can anyone tell me? Yes? When is it reached? That's right. Good. So you know, in your childhood and adolescence, you must have enough dietary calcium and enough exercise as well, so that you achieve a good peak bone mass. Because after 25 years or say 30 years, when the peak bone mass is reached, then gradually your bones start to lose calcium. So early childhood, adolescence, till the age of 30 years, calcium is going into your bones. If at that time, either because of your lack of dietary intake or because you are not doing enough exercise, because exercise also plays a very important role in achieving peak bone mass. So if your peak bone mass is less than optimum, then you are likely to have osteoporosis in your early age, and that to a severe extent. So what is the learning from this is that at your age you should have enough calcium plus exercise as well, so that you achieve a good peak bone mass. So coming to today's lecture, I will be speaking on injuries around the shoulder joint. Okay, it will move from here. Silence, please. So we will first revise the anatomy of the shoulder girdle, and then we will be learning about fracture clavicle, fracture of the scapula, the sternoclavicular joint dislocations, acromioclavicular joint subluxation or dislocation, shoulder joint, proper glenohumeral joint dislocations, fracture of the surgical neck humerus, greater tuberosity of humerus, and the fracture of the humeral shaft. So this is a shoulder joint, shoulder girdle, which consists of three bones, as you all know: the scapula, the clavicle, and the humerus. And these three bones, which make the shoulder joint, connect your appendicular skeleton, that is the upper limb, to your axial skeleton. So as you know, the clavicle, which is on the front side, it is actually S-shaped, with medial side being convex forwards and the lateral side being convex backwards. On the medial side, it joins with the manubrium sterni to make the sternoclavicular joint, and on the lateral side, the lateral end of the clavicle joins with the acromion process, which is an extension of the spinous process of the scapula, to make the acromioclavicular joint. And then you have the scapula, which is a thin flat bone which joins with the humeral head to form the glenohumeral joint. Then you must remember about the rotator cuff, which is made from the insertions of the subscapularis muscle, supraspinatus above, and infraspinatus tendons. They all three tendons make the rotator cuff of the shoulder joint. Then you have biceps, long head of the biceps tendon, which passes between the greater and the lesser tuberosity. There is subacromial bursa, which is beneath the acromial process, and the function of which is to provide smooth abduction at the glenohumeral joint. So coming to the clavicle, as you all know, clavicle is an S-shaped bone, and then there are certain peculiarities about the clavicle. This is the first bone in the body to ossify. The ossification center appears as early as 5th week of the intrauterine life. And not only this, this is the last bone to complete its ossification. It basically ossifies from two primary centers, and they fuse at the age of between 22 to 25 years of age. This is the only long bone which ossifies from the membranous. Rest all long bones have cartilage engonadal ossification. This is the only bone to ossify in the membrane. This is the only long bone which has got no medullary cavity or a very small cavity. And this is the only long bone which is lying horizontally in the body. Rest all long bones are vertical. Its medial end is articulating with the sternum to form the sternoclavicular joint. Lateral side, acromioclavicular joint. Now there are very important coracoclavicular ligaments which is a factor for the stability of the clavicle and the shoulder girdle as such. And this coracoclavicular ligament has got two components, the conoid and the trapezoid. The conoid, as the name suggests, is cone shaped, and it originates from the tip of the coracoid process and inserts on the conoid tubercle, which is on the under surface of the clavicle. And the trapezoid part of the coracoclavicular ligament is a flat part which extends lateral to the conoid ligament. Coming to the scapula, this is a flat bone, and mostly it is covered with the muscles all around it. So three muscles, subscapularis on the ventral side, and the infraspinatus and the supraspinatus on the dorsal side. So the infraspinatus and supraspinatus are inserted over the greater tuberosity of the humerus, while the subscapularis muscle is inserted over the lesser tuberosity, and together they make the rotator cuff. The proximal humerus, it consists of head part, the greater tuberosity and the lesser tuberosity. Head is articulating with the glenoid cavity, and head is separated from the greater and the lesser tuberosity by anatomical neck of the humerus. So this is the anatomical neck of the humerus. And surgical neck is that part of the bone which is an extension of the diaphysis on the metaphysis and joins the proximal part of the humerus. And most commonly we see surgical neck humerus and not the anatomical neck humerus. Coming to the shoulder joint proper, or the glenohumeral joint, this is a ball and socket type of a joint, and it is inherently stable. Why is it inherently stable? Because the whole of the glenoid cavity is not very deep. It is not accumulating the whole of the head of the humerus, unlike hip joint. Hip joint, the acetabulum is quite deep, where the femoral head is engaged, and this is likened to a golf ball on tee, where at any given point of time, whether it is abduction or adduction, external rotation, internal rotation, only 1/3 of the humeral head is articulating with the glenoid cavity. So what is the result? The joint is quite unstable. So for its stability, it has to depend on the surrounding muscles, which have to be strong, the capsule, which has got certain ligaments. So for its stability, it depends on the muscle strength and the ligaments. We'll study in detail when we'll be talking about the dislocation of the shoulder. So now coming to the fracture of the clavicle bone. Very common bone to be fractured. How does the fracture take place? What is the mode of trauma? Either the person falls on the point of the shoulder, that is the most common mode of trauma. Traumatic impact or fall on the shoulder, 87% of the time, most common. Then a direct impact. Now how can a direct impact happen? By assault, by a lathi blow or anything, directly impacting the clavicle and therefore fracturing it. One of the common mode of injuries of upper limb trauma is swoosh or the fall on the outstretched hand. It's a very common mode of trauma, but this method is very rare to have caused the fracture clavicle, only 0.06%. And the rare causes of the fracture of the clavicle include vigorous muscle contraction, as happens in epilepsy or in the seizures or convulsions, or rarely when the clavicle bone is weakened through a process of some pathology, most commonly due to tumorous pathology, when the bone tumor involves the clavicle and it eats away the cortex, it makes it weak, or sometimes infections, the osteomyelitis of the bone. It's a very rare cause, but it can weaken the bone and a trivial trauma can fracture the bone. So most of the time what we see is the fracture of the middle 1/3 of the clavicle. That is the most common. And next common is the lateral 1/3 and rarely the medial 1/3. So what we must learn about is what are the fracture displacements. We are talking of the middle 1/3 of the fracture. What is the common displacement? Why is this displacement caused? How can it be corrected through the treatment? So here you see an X-ray of the fracture clavicle. As you see, this is the proximal end of the bone, this is the distal end of the bone. So what has been the displacement? It's proximal. So what do you say? Is it downward displaced fracture or the upward displaced fracture? Upward, downward. So always describe the displacement in terms of the distal fragment. Be it a long bone, be it clavicle or anything, in whichever direction the distal fragment is displaced, you have to describe this displacement. It is an AP view, so it is clearly showing the inferior displacement of the fracture clavicle. Whether it is anterior or posterior, we cannot find out on this X-ray, because for that we would require lateral X-rays. So what are the factors which are causing displacement of a fracture? Fracture anywhere in the body, any bone fracture, has got two main important factors which determine the displacement. One is the muscle pull. On a particular fragment, what are the muscles attached to it, whether they are strong or not. Secondly, the gravity, the weight of the limb. These two factors determine the type of displacement. So as you can see here, this is the proximal fragment, and what is attached on it is sternocleidomastoid muscle, which is very strong muscle. So this pulls the proximal fragment upwards. While on the distal fragment, what muscles are attached? One is pectoralis major muscle, which is inserted not on the distal fragment but on the upper end of the humerus, bicipital groove, and it pulls the humerus medially, and with it the distal fragment also gets drawn medially. That is one factor. The other is the weight of the limb. So weight of the limb pulls the arm down medially. So these are the common displacements. What do you find on clinical examination? First of all, when you elicit the history, of course, patient will give you the exact mechanism of trauma, how he fell down. And locally you would find that there would be pain, he would complain of pain, he would complain of the swelling at the fracture site. And if you palpate that area, you can feel the crepitus at the fracture site. And the X-ray is then a confirmatory diagnostic test. And as you can see again, this is displaced upwards, this is displaced relatively downwards, and there is shortening also. It is not a minimally displaced fracture, it is rather a displaced fracture of the clavicle. So how do we treat the fracture clavicle? Most of the time, 99% of the time, it is a closed fracture. It is not an open fracture. And majority of the fractures are treated conservatively by figure of 8 bandage. How is this figure of 8 bandage applied? Once you give a cotton padding to both the shoulders, start rolling down your bandage from one shoulder backwards, go to the other side axilla, down under the shoulder, take the bandage up on the same side and bring it down onto the shoulder where you started from and get it up. And in this way a figure of 8 is created, and then you tighten up this bandage. How does it help? When you tighten up the bandage, you brace the shoulder backwards. So by bracing the shoulders backward, your forward displacement on the distal fragment is corrected. Also, through its pull on the axilla, it lifts up the shoulder. So it also corrects the downward pull on the distal fragment. So this is a corrective mechanism. However, it may be quite cumbersome, especially in the adults, and we can do away with using a triangular sling or a pouch arm sling, which does not provide any corrective force to the fracture, but your arm is made to rest and the fracture is allowed to heal. Therefore, this is only applicable in those fractures which are minimally displaced or undisplaced fractures. And once you have given this figure of 8 bandage, pouch arm sling or triangular sling, as soon as the pain becomes less, you start mobilization of the shoulder in 2 weeks or 3 weeks of time to prevent shoulder stiffness. So in those fractures which are severely displaced, it has been seen that the fractures almost always unite, but in those cases where it is severely comminuted or severely displaced, ultimately your shoulder functions suffer. There is some pain or some decrease in the range of movement of the shoulder. So therefore, in these cases now we do an open reduction and internal fixation. What are the implants we use? We use a plate and a screw system to fix the fracture, or sometimes we do a closed reduction and intramedullary nail fixation. Why do we call it a closed reduction when we are putting an internal fixation? This is open or closed? Open reduction or closed reduction? This is a closed reduction. Why we call it closed reduction internal fixation? Because we do not open up the fractures. Then how do we pass this nail? In operation theatre, using a C-arm image intensifier, we get an image on the screen. We make a hole on the medial side of the clavicle. Through that hole, the nail is passed up to the fracture site. The fracture is manipulated closed, no incision over the fracture site, and the reduction is checked under C-arm image intensifier, okay, under X-ray. And once we are sure that we have brought the fractures in alignment, then the nail is then pushed across the fracture. Therefore, this procedure is called closed reduction and internal fixation. So what are the complications of clavicle fracture? Very early complications and late complications. Now, very early complications, as you know, just behind the clavicle is the major arteries, the subclavian artery or carotid artery. And if there is especially direct injury and there is severe displacement, there may be an arterial injury. Underneath is the chest cage, rib cage, and it can cause trauma and pneumothorax and pneumothorax can result. Or just on the middle of the clavicle, just underneath that is the brachial plexus, so it can cause brachial plexus injury as well. So these are the early injuries in case of very severe trauma. Late union, late complications, the first and foremost is malunion. If you have not done an open reduction, then it will lead to some sort of malunion. It may be symptomatic, it may not be. If the fracture is minimally displaced, it will not cause any symptoms except for a mild deformity on the clavicle. Non-union is very, very rare. If the fracture is comminuted, if no kind of immobilization has been used, if the patient continues to use his extremity, no rest is given, it can lead to non-union. And the treatment for non-union would of course be an open reduction, internal fixation, and bone grafts may be required in those cases. Late complications of neurovascular injury is rare. Rather, during surgery we can, because of the mishandling of the bone fragments, because of the not properly using the implants, you can cause neurovascular injury. In elderly, it can lead to stiffness of the shoulder. Ulnar neuropathy, again because the lower trunk of the brachial plexus is very, very close to the clavicle, so lower trunk injury or ulnar neuropathy can take place, and sometimes refracture. So now coming to the fracture of the scapula. Fracture of the scapula is very uncommon because of its location and surrounding muscles which are protecting the scapula. Fractures of the scapula are result of very high energy trauma with high incidence of associated injury by 60 to 98%. Since it is results from a very severe trauma, once there is fractured scapula, it is often associated with life-threatening injuries like pneumothorax, pulmonary contusion, any arterial injury, abdominal injury, head injury, splenic or liver laceration or brachial plexus injury. Mechanism of injury is very severe. It can result from fall from a height with direct landing on posterior aspect of the truck, and most commonly we see the road traffic accidents in which we see these scapular fractures. How does it present clinically, or what are the signs and symptoms? There is bruising over the scapula or the chest area. When he is asked to move the shoulders, there is pain. there is swelling around the back of the shoulder, and obviously when you feel it, there is tenderness, and arm is held immobile. This is how the patient presents. Most of the time scapular fractures are treated closed conservatively, and scapular body fracture, the reduction is not required because it is very thickly covered with muscles. Simple sling is advised. Now there are two important things which are associated with the fracture of the scapula. One is floating shoulder. So what is a floating shoulder and what is a scapulothoracic dissociation? Now these are serious injuries which often are seen with fracture scapula. Floating shoulder is defined as a condition in which there is ipsilateral scapular glenoid fracture with mid-shaft clavicular fracture. And there is a strong case for open reduction and internal fixation. And what is scapulothoracic dissociation? It is severely life-threatening. There are fractures in the clavicle, scapula, and the first rib. Now coming to the sternoclavicular joint dislocation. This again is a rare injury. On the medial side, there is sternoclavicular joint. The medial end of the clavicle is displaced forwards or rarely backwards. A backward displacement of the clavicle is very, very dangerous because, as all you know, there are neurovascular structures just behind the sternum. Clinical diagnosis is very easy, and it is treated by reduction by a direct pressure. We are talking of the forward dislocation. You just put a direct pressure on the sternal end of the clavicle, reduce the dislocation, and then maintain this position by figure of 8 bandage. Coming to the acromioclavicular joint dislocation. Now here you must remember about these ligaments which are giving stability to the acromioclavicular joint. So the important ligamentous structures, as I told you before, is the Coracoclavicular ligament. This is the conoid ligament, which is a conoid shape extending from the tip of the coracoid over to the conoid tubercular on the under surface of the clavicle, and the trapezoid part which extends laterally. So this is a very strong ligament which keeps the clavicle down. It prevents upward displacement. And second is your acromioclavicular ligament. This is also a stabilizing structure for the acromioclavicular joint. As you see in the X-ray, there is a displacement. The two bone ends, the lateral end of the clavicle and the acromial end, are not close together, so there is an obvious dislocation. So this is uncommon injury. It is caused by fall on the outer prominence of the shoulder. There is always a localized pain and swelling on presentation, and you will find that the lateral end of the clavicle is always prominent. Rockwood actually has classified this injury, dislocation, into 5 grades, and it is very important to grade this dislocation because depending on the grade, the management of the acromioclavicular dislocation depends. So what happens in grade 1 is, as I told you, these are the two important ligaments, coracoclavicular and the acromioclavicular ligament. So in grade 1, there is just a sprain of the ligament. The patient comes with a history of fall on the point of the shoulder, complaining of pain. What you see on examination is there may or there may not be a bruised over the skin. There is no obvious deformity, but if you palpate deep, there would be some tenderness. So this is grade 1 acromioclavicular injury. What happens in grade 2? There is complete injury to acromioclavicular ligament, and there may be mild displacement of the lateral end of the clavicle. Of course, there will be some tenderness. In grade 3, not only the acromioclavicular ligament, but coracoclavicular ligament is completely torn. So this, what happens in this? There is 1/3 to almost a complete dislocation of the clavicle. So these two grades can be managed conservatively in pouch arm sling or in shoulder strapping. However, in grade 3, where there is an clinically obvious displacement of the clavicle, you simply cannot reduce it. You momentarily reduce it, but it is difficult to hold it down because both the stabilizing structures, the coracoclavicular ligament as well as acromioclavicular ligament, are injured. So by surgery you have to do a reconstruction. So in sedentary people, in old age people, where not a very strong force is required for the person, you can treat this injury conservatively. But in active athletes or young people, you go for the surgical repair of the ligaments. In grade 3, both ligaments are injured, but actually the lateral end is pushed backwards and gets entrapped in the trapezius muscle. It is clinically obvious. You would find that the lateral end of the clavicle has gone backwards, and there is a lot of swelling, tenderness over this pair. In grade 5, there is superior migraine, much, maybe 2 times or 3 times the joint width gets displaced, high riding clavicle. And in grade 6, this clavicle is taken down, it gets an inferior displacement. So again, these 3 definite indication for surgery. So 1 and 2 conservative, 3 depending upon the personality of the patient, conservative or operative, and grade 4, 5 and 6 surgery. So that is all about these injuries. We shall be discussing the other the shoulder dislocations all in my next